We look at the way that we act. We talk about why do leaders not lead? Why is it that I can walk into a room and I can see several different things happening that everyone knows should not, but the leaders in that room see the same things and they don't act? And that's often because these are very difficult conversations. Yeah, but this is part of the problem. This is what we would call the elephant in the bathroom. That we need to look after each other. We need to tap each other on the shoulder and say, excuse me, you just did this or you just did not do this. And the other person should say, thank you. So human factors is one of the very, very important elements, but very soft. But again, there's an expectation that you will look at this in a structured way. You will have processes. You will look at what is good practice. You will monitor, you will measure, and you will improve. Facility requirements. I have seen, 50 hospitals. I have never seen two the same. I have seen in one hospital 5 different types of isolation room. I have seen right-handed rooms. I have seen left-handed rooms. I have seldom seen a room that is too big, but I have seen many, many rooms that are too small. So the way that hospitals are designed, the opportunity for standardization, etc., I think is huge. Some of the hospitals are big hospital groups, and there's a really big opportunity to look at the designs, own the designs. If there are problems with architects and suppliers, it's really important the hospital really understands these designs themselves and has a very structured risk assessment, specification, and design process. So the buildings, big issue, lots of money. Everywhere you go, you see problems. Many of the problems can be solved relatively simply by implementing more standardized design procedures. So that is part of facility requirements. Healthcare environment, very, very important. Laundry and linen, kitchen, the support services who not only need to provide services which are of a very high quality, these are people who go into the patient rooms. These are the people who come into close contact with the patients on a daily basis. If you don't have clean rooms, you have got a big problem. So these are not support people who live down the corridor and do a little bit. These are absolutely central people in terms of controlling infections in the hospital. So we spend a lot of time talking to laundry, linen, kitchen, housekeeping, etc., not just to tell them that they're important, but to talk to them about how they can systematically improve the work that they do in relation to infection control. And once you tell them that they're important, they absolutely know. They understand all of a sudden, I'm not just cleaning a room, I am potentially preventing infections. And we've seen some great results where people have looked at these activities and really shown measurable improvements. Cleaning, disinfection, decontamination, 2 sides really. One is when you have potentially hazardous materials. So maybe a material which is contaminated, etc., which could be anything from surgical dressings. It could be curtains. Hospitals are no longer hospitals. Many hospitals have become hotels, so they have lovely cushions, they have nice frills. For me, very difficult to clean, very difficult to decontaminate, etc. So looking at some of these very, very simple areas, and then of course the other side is things like sterile supplies. So how do we maintain very, very high levels of cleanliness, sterility, etc., through cleaning, decontamination? So again, lots of time in places like CSSD, lots and lots of time in endoscopy. So looking for processes which are vulnerable, because generally if you want to do a good decontamination or sterilization, you add lots and lots of heat. If you add heat to endoscopes, they don't work very well afterwards. So you have a process which by definition is challenging. The environments are often challenging, etc. So we spend lots of time in places like endoscopy. Sadly, in recent years, there have been some examples of where this has gone seriously wrong. So there have been instances where there have been a number of infections through the things like the misuse or poor processing of endoscopes. And again, when you go to the hospitals looking at the simple step-by-step processes in areas like endoscopy, you've got the potential to prevent a major incident. Patient care, which is really at the center of the whole exercise, which looks at the clinical pathways, looks at things like bundles, really looks hard at competency, etc. I think at the moment the standard is really in its infancy, so it's still quite new, but I think in 10 years' time we might be having a very different discussion about clinical risk assessments based on infection control. People tell me in some of the hospitals they have 15 surgeons and they have 15 different ways to change a knee. That may be ideal, but for me that sounds like there might be quite a lot of variation in some of the processes. And again, the focus is really to look at what is done. Is it evidence-based? Is it good practice, etc.? So a lot of time in cath lab, going to some of the really critical areas where high standards have to be maintained, going to the ORs, etc., ICUs to look at the practices there. Singapore, where I currently live, please don't tell the Singaporeans that I showed you this slide. They had a very bad experience, I think 2 years ago now, with hepatitis C. The truth of the matter is they really don't know what happened. So there was an investigation. If you want to learn a lot about some of these areas, read the investigation reports and then draw your own conclusions in terms of, was this really the cause, or do we really not know what the cause actually was? But there was a big outbreak, resulted in a number of fatalities, hepatitis C, and of course the finger was pointed very firmly towards breaches of infection control practice. To be honest, some of the breaches they pointed out, I think you could go to many, many, many hospitals and see very similar situations. So I suspect in this case there was something which went catastrophically wrong, but again a very good example that when it happens, very serious for the patients, very serious for the hospital, etc. Hand hygiene, huge problem. Hospitals struggle everywhere with hand hygiene. Lots of different ways being invented to try to improve this. And again, the standard says that you will have a program. The program will be systematic. You will measure, you will monitor, but also the elements all interconnect. So if you have a supervisor and they have a 30% hand hygiene rate on that particular ward, the question should be asked, what is the responsibility and the accountability of the leaders in these units? Should these people get a bonus? Should these people be rewarded? So lots of good discussions around hand hygiene, personal responsibility, leadership, etc. And everyone says it's such a big issue, it's the biggest, etc. in health. And you go in and you say, what's your policy on jewelry? Why do all these people who need to sanitize their hands have enormous watches, big diamond rings, sleeves which come down to here? This is really one of your number one priorities? So really asking some of the difficult questions, not just in terms of the theory, but when you walk into an OR, you should not see finger rings. You should not see watches on wrists. Should you see mobile phones? You should not be seeing mobile phones, but I can tell you, if you want to call somebody in the OR, there's every chance they might pick up, at least in some of the hospitals, some of the time. So again, looking at some of these areas and saying, what are we doing? Can we do it better? Clothing and PPE. So again, one of the problems in healthcare is that you have to get very close and personal with the hazard, which is often a human being. So the areas where I work, what we try to do is we try to keep it inside a cabinet. We try to keep it inside a bottle. We try to keep it inside a pipe so that we have primary containment. So PPE becomes much less important because you're not exposing the worker. In healthcare, that's much more difficult because you have to handle the patient. So there's the risk of the worker infecting the patient, but also in many cases, the patient infecting the worker. And one area which I think has really raised concern has been Ebola, has been SARS, has been MERS, where there's been a huge reaction in terms of the workers concerned that they themselves may be exposed, may be infected, may take this home. So PPE is a very important area, but it's often handled very badly. There are rules that people do not follow. The logic of the PPE controls is not always clear. And the most notable example that we've had recently was with Ebola, when, surprise, surprise, we found that maybe we're not quite so good at putting PPE on and taking it off as we thought we were. And Ebola is very interesting, but for me, the really, really interesting thing is, if it happens with Ebola, do you think it happens with MRSA? Do you think it happens with C. diff? Absolutely it does, just the same. It's just that you don't see the same outcome when you get transmission through some of these other pathways for some of these different organisms. So Ebola, very interesting because it raises attention of these particular issues, but actually we can take the same thinking and apply it to some of the day-to-day organisms which actually cause the real harm in the hospitals. So the hospitals who are doing MIR, the ultimate objective is to become certified as a center of excellence. And it takes a little bit of time. It takes quite a lot of thought. Poor Janya is going to talk about some of her wonderful experiences of sitting in a room with me for many hours talking about infection control. But it really is something that you need to take a step back. You need to think about where you're going, what you're doing, how you're organized, etc., using infection control as a theme. I think the hospitals get a lot more than infection control from this particular standard because I think it really helps them understand management systems using some very, very practical and obvious examples associated with infections. And the way that the process works is at the beginning we go in and we basically do a gap assessment. And we say, this is where you are. Where would you like to go? How quickly would you like to go there? And we do some training, and then in the gap assessment, we basically train the whole organization in terms of this is your role, this is why you're important, and this is what we're trying to do. And we have had very, very good feedback and response from these exercises. The people seem to be genuinely interested in talking about this in a way that maybe it has not been presented to them before. Then there can be trainings, other gap assessments, etc., before the certification visit. For most hospitals, probably take 1 to 2 years to achieve certification. Some may be quicker, some may take more time, but it's not something that happens at the end of the first week. It really is very much a journey. And these are some of the hospitals that we've been working with. I'm very happy to say that finally in Asia we have got some momentum. Much of the early work was done in the US, but my own personal mission is to bring this to Asia, not just to Thailand, to countries like India, to countries like Vietnam, countries like Bangladesh, where the problems with infection control are massive. 40 to 50% hospital-acquired infection rates in some hospitals in India. If you could drop that by 5%, what a difference you could make. And you'd be making a difference to people who really cannot afford to be in a situation where they are sick, where they are hospitalized, and they are getting sicker and sicker. So I am very grateful to Thailand. I'm very grateful to the hospitals who have been working with us in this, and I hope that in years to come we won't only be doing it in some hospitals, but we will be doing it in many. And I think the relationship with HA is very, very important in Thailand in developing the program here, and hopefully it will extend to many other countries also. So I just have a few photographs to conclude, a little bit lighter, a little bit away from some of the theory. MIR is not all about documents. Okay, I find documents extremely boring. But people bring documents and they often have to bring them on wheels because there are so many and they are so heavy. And we need to make sure that there is a system. So quite a lot of the time at the beginning is to say, how are you organized? What are your standards, etc.? But really the interesting part is when you go into the hospital and you connect the theory with the actual practice. So part of MIR is about documents, but really that's not the main focus. The main focus is, have we identified good practice, and then do we use the documents, the training, etc., to make sure the people who do the work know what to do, and they do it every time the right way. It's about working together. So often we go into a room, and I would be used to going into a room where there would be 6 people, and there would be 60 people. And the people would be interested, what have we done, what have we found, questions from all kinds of people. So it's really about working together, and it really shows that any one group in the hospital cannot control infections. For sure, the infection control officer cannot control infections. That is an advisory person. Everyone has to do their part. And again, we have many, many examples of good teamwork, people working together, engineers coming up with examples of how the hospital can improve infection control, etc. I don't know if you recognize this gentleman. Very, very important to have good leaders. So Dr. Montre has been a very good leader, not only for HA, but in his own hospital. Jania has been another example of someone who has really taken this and said, I think this is something worth trying. I think this is new. I know this is not going to be so easy, but I think it's something that we should do. So really having people in the organization who are going to champion this, who are going to say this is very important and going to do it. And it's not a legal requirement. There is no regulator saying you must do this. So the hospitals who are doing it, they are doing it because they believe it's the right thing to do, which I think is the right reason. In individual hospitals, demonstration of leadership. Hand hygiene is important to me. It should be important to you. One hospital we visited in the US, and I was talking about leadership, and the chief executive said, should I come in on Monday with a t-shirt saying, I love infection control? And he was joking. I said, you absolutely should. What a difference that would make to your organization. In Thailand, we see this all the time. We see posters, we see presentations, we see senior leaders in the hospital standing up and saying, this is important to us and this is important to our patients, which is very, very important. People are interested. I wouldn't say they're always interested when we go through the documents, but generally the people understand what we're talking about. They don't get tied up in management system theory and auditing because we're talking about, is it clean or is it not? Are you contaminated or are you not? Do you know what your supplier is doing or do you not? Do you know what antibiotics your physicians are prescribing, and are they the right ones, or do you not? So it's a very, very practical and applied subject, and generally we don't get feedback that people don't understand. We don't get feedback that people think it's boring. They see it for what it is, which is a really, really important area. This is the one in the middle here. This is me. You might not recognize me, but actually that's me. So we go into some of the clinical areas. We go right back to basic principles and we say, how should an OR work? Do you know what happens to the air in your ORs? Do you know what happens with the air in your isolation rooms? So we go in and we start to ask the questions, we take some smoke, and people begin to see that they work in an environment which is designed in a particular way. Often they have no idea how it has been designed. Okay, so a lot of it is very practical, going into the critical areas to have discussions in terms of how the work should tie in with the facility, and if it doesn't, that can be a big problem. CSSD, very, very important area. So we go in there. CSSD are very lucky because they have lots of standards. They have big, thick books. When they give me the book, they always say, please don't take the book because it costs $450. I go to tube feeding in the kitchen. There is nothing. So again, some areas are very fortunate because there's lots of standards and guidelines. Other areas, it's really more difficult and much more about risk assessment. But these are some of the critical areas. Another very, very critical area, this is the kitchen. This is the lady who handles the dishes. And if she doesn't handle the dishes properly, and she has an isolation patient, what happens to the plate? Next time, it may be off to cancer care. So if this lady here doesn't know that this is the clean side, and this is the contaminated side, and there's only one person, and the poor soul is very busy, so she puts them in here, and then she comes here. No change of PPE. Do I have clean dishes? 5 minutes is all it takes to explain some of these things to some of these people, and all of a sudden they begin to realize the importance of the procedures and the PPE changes, etc. This is a transport team from one of the Payatai hospitals. You will never see more interested and engaged people in your life. They want to know all about transport. They want to know how they should be cleaning the equipment, where they should be storing the equipment. Should they wear gloves? Should they not wear gloves? Absolutely engaged in the process and understand the role. Smoke testing in an OR. So again, very, very simple, but if you don't understand the environment, you will never get the benefit of the engineering controls. So some of the most interesting things we do are going into these environments and talking to people about how they work. We don't always know, to be perfectly honest, but we can usually have a discussion. This is the theory, this is what we're seeing, etc., and it changes people's perspective. This is a portable HEPA filter. So you will see that we use some very, very expensive and sophisticated equipment when we do these assessments. But this was a very good example because this filter blows 360 degrees. And I am the worker, and this is the patient, and this is the filter, and my 1,000 baht note shows that when that patient coughs, it's coming straight to me. Okay, so again, applying very, very simple theories, directional airflow, what is the equipment designed to do? Because if you don't, this piece of safety equipment becomes a real hazard. Okay, so it's not all antimicrobial programs and management. A lot of it is really, really simple common sense and taking it to the people who need to know. And this was some work that we did training the HA auditors. And I am a firm believer that people like me can only be partially effective in different countries, and this really needs to be embedded in the country. And you can see this week, I think there's 7,000 people at this conference. So if we can work with HA, different organizations, to bring this not to the few hospitals, but to the many, I hope we will see some real advances in infection prevention and control. So that's pretty much all from me. Just have a few conclusions before I pass over to the others, and then we can take some questions at the end. Are we winning or losing the battle against infections? There's a new significant infectious disease emerges roughly every 2 years. What have we had in the last decade? We've had Ebola, we've had SARS, we've had MERS, multi-drug resistant tuberculosis. So this is something which is going on and on and on. More and more people want to eat meat. When they want to eat meat, it's often pork, it's often chicken. You are beginning to build industrial-sized generators that can potentially provide the next big infectious disease issue. So on one side we have that. On the other side, are we really dealing with C. diff? Are we really dealing with flu? Are we really dealing with measles? So the microbes are getting very smart. Antimicrobial resistance, I think we need to do some new things in order to keep one step ahead. The opportunity for both public and private hospitals, I believe, is very large, not just because of infections, but because this really crosses over into good safety management practice, good quality management practice. It's not all about infections. It's really about organizations, it's about risk assessment, it's about structured policy setting, ownership down to individual level. So I think it's a very interesting standard, even for hospitals where infections are not the #1 priority. And I would be surprised if there are many of those. Everyone has to be involved. So if you're the housekeeper, the transporter, the senior physician, everyone is involved with MIR. Really is cuts across every department and every activity. I think that we have a real potential with this to release the inner power. I think it really empowers people. It gets people to understand their responsibilities, understand their ownership. And that's, for me, probably the most exciting thing about doing this work, is it's not DNV standard. It's not necessarily even Bumrungrad standard. When you see the guys in Bumrungrad in the mortuary, you go back the second time and they say, we've changed our PPE. We now have all our instruments cleaned in a different way. You begin to see that you're reaching the people who actually do the work. And that really is giving the people the opportunity not only to work more safely, but also to help the patients. So thank you for your attention. I will pass over to Dr. Montre, and then at the end we can take some questions. Thank you.
Thank you very much, Paul. Swadikap. Good morning. So I'm going to talk to you this morning about the MVGL MR program and also Advanced HA. And first of all, I would like to introduce you all to concept of Advanced HA. Actually, I think both of all of you